The objectives of today's presentation, before we even talk about end-of-life care, we're going to begin with an overview of health disparities and the impact of the social determinants of health. We're also going to talk about how is hospice beneficial and what are the implications when certain groups do not access hospice care. We're going to look at the data, who uses hospice care the most and who uses it the least. And then we're going to look into some of the potential reasons for that or the factors that cause that. And there are many, but specifically medical abuse, discrimination, exploitation, and kind of how this legacy has led to mistrust in the healthcare system. We're also going to talk about what's going on currently, issues of inequitable care and provider bias. And then finally, solutions. We're really going to talk about what providers, CHWs can do to address disparities and ensure access to culturally affirming care for all, and really work on repairing trust and building trust. So it's always important, but it's especially important with today's topic, medical mistrust, that we take a moment to acknowledge, to do an Indigenous land acknowledgement. And what this basically means is just acknowledging that all of us, no matter where we are in the US, we live and work in a country that was born from colonization and seizure of Indigenous lands. So with that in mind, I would just like to acknowledge that this meeting is being held on the traditional lands of the Odawa, Ojibwe, Potawatomi, Munamuni tribes, and pay respect to the elders, both past and present. This is not just, a historical issue. Chicago, which is where we're coming to y'all from, is currently the third largest urban Indigenous population, and more than 65,000 Native Americans call Chicago home. So we just wanted to call attention to that land acknowledgement before we get started. So in terms of health disparities, what are these? Most of y'all may know, these are preventable differences in the burden of a disease, injury, or opportunity to achieve optimal health between groups. So the key word there is preventable. These are injustices when a health outcome is seen to a greater or lesser degree between different populations. Health disparities exist in nearly all aspects of our healthcare system. And disparities can be related to a specific outcome like life expectancy or cancer rate, but they also exist in utilization of services. So things like enrollment in health insurance, getting prenatal care, or as we're going to talk about today, usage of hospice. And why do disparities matter? They're unjust and they contribute to health inequity. When people who belong to certain groups don't have the same access and resources to live healthy lives, this is a preventable injustice that should matter to all of us. And with that, I'll throw it over to Kandis.
So when we look at this slide and we talk about social determinants of health, there are different individual factors that you have to take into consideration. Age, gender, and genetics is one. It goes all the way up from individual factors, behaviors, public service and infrastructure, living and working conditions, and social, economic, and political factors. So all of these are what we call social determinants of health. Next slide. So this is a quote that we found actually that, we thought would be really good to add into the presentation. So perhaps it goes without saying that the inequities historically underserved communities face throughout life continue throughout the end of life. So it talks about, so this quote is from Addressing Inequities in End-of-Life Planning and Care. So this quote really talks about how underserved communities, when you are faced with many different elements, it continues throughout the end of your life if those things are not addressed in a timely way, whether it's, housing insecurity, health insecurities, things that, affect your well-being as a person. If those are not taken into consideration and dealt with, that can continue on throughout your life. Next slide. So hospice care is designed to give supportive care to individuals who are in the final phases of a terminal illness. Hospice care focuses on comfort and quality of life. Once you get to a hospice stage, it's not really about anything medically at that point has been decided that it will not work anymore. So then now we have to focus on comfort and quality of life. And hospice care involves a team-oriented approach to expert medical care, pain management, and emotional and spiritual support. Next slide. So to be eligible for hospice care, 2 doctors must certify that the patient has a prognosis of 6 months or less to live. Unlike palliative care, hospice is for those who are no longer pursuing curative treatments, and Medicare Part A covers all aspects of hospice care and services, and Medicaid offers similar coverage. Next slide. So this is a graph that shows hospice utilization disparities by race in 2020. So if you look at the left of the graph, you can see the hospice utilization by race compared to the Medicare descendants by race. And it shows that 50% of whites compared to 36% of Asians, 35% of Blacks, American Indian and Alaskan Native, 33%, and Hispanic, 33%. This shows the hospice utilization, and one of the things that we are trying to address and trying to continue and correct is for more people to have access to hospice care. Next slide, excuse me.
I think that's me. Well, why is this important? Well, we want everyone to have equal access to hospice care. And the goal is to ensure that every person, regardless of race or ethnicity, understands how hospice can serve them and their loved ones. And this is important because hospice users report higher quality of life, higher levels of comfort, and lower levels of pain. And believe it or not, they also live longer as compared to individuals with similar disease processes who don't use hospice care. Additionally, serious illness can be really, really hard on family members, friends, caregivers. And hospice takes a holistic support approach to care and offers grief services. And so the hospice benefit impacts not only the patients, but also those around them, their family members, and their loved ones. Most hospice patients remain at home, and expert care comes to them. And this really helps prevent unnecessary hospitalizations. Enrollment in hospice ensures that patients are not subject to painful procedures or aggressive treatments that don't benefit them or that they don't need. And it really allows patients and families to have a strong voice in their goals of care or the direction they'd like their care to go. So I think it's really important to know with hospice that just because a disease is noted as being incurable, there is still much that can be done to support the physical, mental, emotional, spiritual health of the patient and of their families. Next slide, please. So this slide demonstrates one impact of disparate access to hospice services. This graphic represents a study that showed how many days people spend in the hospital during the last year of life. And you can see that compared to white individuals, Hispanic individuals spent 5.6 more days in the hospital during the last year of life. And Black individuals spent an additional 8.2 days in the hospital during the last year of life. And so this is just kind of a visual to see one impact that this disparate access to hospice care can have. Next slide, please. Thanks, Maureen. So we wanted to share a little bit of research with you about the disparate use of hospice and palliative care. So looking at the first bullet point here, studies consistently document lower rates of hospice use for minority adults than for whites across diagnosis, geographic areas, settings of care, including nursing homes. So this is a study that indicates it's not just the location, it's not an area of the country, it's not urban versus rural, but across multiple evaluated domains, there are disparities in the utilization of hospice care. And then the second statistic on this slide looks at the Medicare population and demonstrates again the disparate use of hospice when targeting only that payment modality. And so we just continue to see disparities with hospice utilization among white individuals at about 45%, and African and Hispanic individuals demonstrating lower utilization rates at 37 and 28%.
Status of Medicare application.
I'm sorry, it sounds like someone may have a question, and maybe I'll just have you throw that in the chat and we can address it as we move on. So I think the question from some of this research becomes why? Is it related to personal choice? I mean, maybe sometimes, but I think the evidence that we see from continued research and what HAP has seen in their own experience really begins to lay out a story that there is disparate access in certain communities to conversations and to options that would allow individuals and families to remain at home and to utilize serious illness care, including the hospice benefit. All right, Maureen, next slide. So again, why the disparity? Well, one thing we're seeing in research is communication. Empathetic communication is such a critical part of hospice and palliative care. So you'll see in the first bullet, a study of cancer patients evaluating communication showed that the quality of the dialogue differed by race with end-of-life discussions, and that physicians were actually less likely to participate in conversations that resulted in care being consistent with the preferences of Black patients when compared to white patients. And so here's a study showing that one of the critical elements for understanding goals of care, conversation, communication, has inherent quality disparities lodged within it. And the second study looked at the Latinx population and another communication failure. And hospice translates or sounds very much like the Spanish word, and I do not speak Spanish, so I'm going to apologize ahead of time, and maybe after those who do could correct me, but hospicio in Spanish, which means an orphanage or a place for poor people. So patients and family members could interpret the offer of hospice as substandard or inadequate treatment. And you know, why would someone want to utilize a service that they understood as being substandard treatment without further fleshing out in communication about what hospice and palliative services are? Next slide. So another reason for disparate access is planning. We are finding that so much good end-of-life care has to do with conversations with family members about desires of care, with doctors about options, and advanced care planning is really a huge part of that. So in the first bullet point, you see advanced care planning studies reveal that among the population surveyed, only 18% of minority participants had completed advanced directives, while 34% of white respondents had done so. So we're seeing disparities in the documented results of the conversations that would impact people's decision to use hospice and palliative care, or early conversations about utilization of that care. And I think too, it's really important when looking at the research to touch some upon structural racism issues that extend from hospice back into the serious illness space. There was a recent article that came out this year that looked at Black veterans with chronic kidney disease and noted that they experienced racism in the clinical setting that produced physical and emotional stress and a strong sense of distrust in the healthcare system. And so if that's going back into the serious illness space, it is impacting, again, the conversations and the ability to engage in empathetic and trusting conversation about goals of care and options. And so I'll also note that HAP is currently engaged in a research study in partnership with NORC at University of Chicago that we're really grateful to be involved in. And Kandis Draw, who's a co-presenter today, had a leadership role in the development of this research project. And we're in the data analysis phase of a qualitative research project. So we're looking at interviews and focus groups to better understand the knowledge, attitudes, and behaviors around hospice and palliative care for Black communities living in Chicago. And it's been just absolutely an honor and a privilege to be a part of this study. As we're working through the data analysis, we are working towards having a formal executive summary of our work that will be available on the HAP website in March. And we will also look forward to disseminating out the information to this group when it is more formally available. But I just thought I would share about that project. Kandis, before Maureen takes over, did you have anything else that you'd like to share about? No, we're good for now. So I'll pass it back over to Maureen.
Thank you so much, Kim. So now I'm going to talk about some of the causes of utilization disparities, and there are many. But as we go through these different bullet points, many of them are connected to medical mistrust. So a lack of trustworthy providers, medical mistrust that results from discrimination, lack of providers who look like you or who understand your cultural norms, issues with language capacity and cultural attitudes, and then finally, a lack of awareness by patients of what hospice is, what palliative care is, and appropriate education on how and when to access it. So this presentation is mostly focused on medical mistrust. So when we say medical mistrust, we are talking about many different things. And I could probably do an entire presentation on each of these 3 bullet points. But as we go through them, we're going to start to see that there is a long legacy of our healthcare system proving itself to be untrustworthy. So as we engage in this conversation, it's really important that we not frame medical mistrust as something that communities of color need to get past, because that is false. In many cases, medical mistrust is 100% warranted. So it is something that our government, our society, our healthcare system, and providers of care, professionals like all of us speaking and in the audience, is something that we need to reckon with and address, and it's really on us to do better. So we are going to talk about medical abuse and experimentation throughout US history, historical racism and discrimination in healthcare, and then current discrimination and inequities that persist right now. So I do just want to give a brief trigger warning before I launch into this next section. This is a hard topic and it's a devastating history, but we really need to educate ourselves about it in order to reckon with it and do better. So as we discuss this history, I just want to give that warning that it might be hard to hear, it can be shocking, and the intent is not for shock value, it's just to reckon with these events honestly and openly so that we can all try to do better and create a better system that is more worthy of trust. So talking about colonization, genocide, and experiments on Indigenous peoples, it's pretty well known that the Indigenous tribes of the Americas were decimated by European diseases. So Europeans came over and the Indigenous folks did not have immunity to the diseases that they brought with them. And in addition to that, there were, of course, many wars, but some of these diseases were actually spread intentionally, including in 1763. That was the first documented case of biological warfare by the US military, when they intentionally distributed blankets that were infected with smallpox to Indigenous tribes. Also, between 1819 all the way to 1969, the US ran or supported about 400 residential schools. So these were boarding schools, and Indigenous children were forcibly removed from their families and sent to these institutions to be assimilated. So there's a lot of trauma associated with this, children not being allowed to speak their native language. There was poor sanitation in the facilities that led to disease outbreaks, and there was rampant physical and sexual abuse. There's also evidence that at least some of these Indigenous children were also used in medical experiments. So specifically, the Proctor Foundation was researching a treatment for trachoma and experimented and tested it on some of these children in the residential schools. And then between the 1960s and 1970s, the Indian Health Service, which is the national entity, that's tasked with providing healthcare to Indigenous people, sustained a practice of performing forced sterilizations on Native American women. So in many cases, women were permanently sterilized without their consent or without understanding what the procedure was. This included cases of minors as young as 11 years old being forcibly sterilized. So because of this legacy, there's a lot of trauma and a lot of mistrust, and disparities also persist due to lack of access to care in these Indigenous communities. Next, I want to talk a little bit about the eugenics movement. So the idea of eugenics, it's kind of a junk science, racist science that thinks that we can improve the quality of the human race by encouraging some people who have desirable traits to reproduce and discouraging others with weaker or less desirable traits, discouraging them or stopping them from reproducing. So it's important to understand that this field of eugenics reinforced the racism of the time. So people thought that these, desirable genes, they associated them with whites or Europeans, and the less desirable genes were associated with people of color, people of lower economic status, or people with physical or mental disabilities. So in the US, it was mostly a negative eugenics movement, which means it really focused on preventing people who had been deemed to have undesirable traits, preventing those people from reproducing. So in 1907, Indiana passed the first eugenics-based compulsory sterilization law in the world, and 30 US states would soon follow their lead. Between 1907 and 1963, over 64,000 individuals were forcibly sterilized under eugenic legislation in the US. And of course, this policy of forced sterilization disproportionately impacted Black Americans, Indigenous Americans, Puerto Rican Americans, and people with disabilities and people who were incarcerated. So now talking a little bit about the era of slavery and the exploitation of Black Americans. For centuries, science and medicine have been used as weapons against Black people, serving to both justify and perpetuate racism. So I think it goes without saying that during the era of enslavement, people who were enslaved did not have access to medical care. They weren't viewed as people. And if they did get any type of care, it was likely to be substandard or just enough to ensure that they could continue working, continue producing. There was also a lot of experimentation and abuse on enslaved people, which I'm going to talk about a little bit later in the presentation. And then even continuing past the era, during the era of slavery and past it, there was a sustained practice by the US medical system and American educational institutions, where when they needed cadavers for research, they would rob Black cemeteries. And I think this is especially important to know because we're talking about trust and we're talking about end of life. And a lot of end of life is about dignity and respect and how we memorialize people. And so I think it's important to note that this abuse was not only when enslaved people were living, but even continued after their death in the form of, violating and desecrating their graves. So many of you may have heard of Marion Sims, who is commonly credited as being the father of modern gynecology. So he developed some very pioneering techniques related to women's reproductive health. But sadly, all of his advances in gynecological care were born from the abuse and mutilation of enslaved Black women. So he performed experiments on enslaved Black women, including, using primitive tools, no anesthetic, sterilizing these women, and mutilating their genitals, all in the name of science. Then moving forward, that was occurring in the 1840s. And then moving forward all the way to 1927, another example of our system proving itself to be untrustworthy is the Lyle Station radiation experiment. 10 African-American students were chosen to be part of what they were told was a treatment study for ringworm of the scalp. But they were not given any ringworm treatment. Instead, they were exposed to high levels of radiation as part of an experiment. And as you can see from the picture, this led to trauma, disfiguring scars, physical complications, and emotional trauma that many of the victims dealt with for the rest of their lives. And then moving ahead to what is perhaps the most commonly known instance of abuse in our medical system, the Tuskegee syphilis experiment, where 600 poor and mostly illiterate African-American males, 400 of whom were infected with syphilis, were monitored for 40 years. They were denied treatment and lied to while the disease was allowed to ravage their bodies. So continuing on and talking about the Jim Crow era and the fight for civil rights, it's pretty well known that, from the time period of Reconstruction on until the Civil Rights Movement, African Americans were legally oppressed, and they were forced to, use separate facilities, including in healthcare. And so they were not allowed to access white hospitals, and the hospitals and doctors that they were allowed to frequent were usually, poorly funded and not up to the same standard of care as the white hospitals. I feel like the fight for civil rights and integration is pretty well known in our public life, but what's less well known is sort of the healthcare aspect of that. There was a group of Black physicians who played an important role. The Medical Committee for Human Rights was kind of like the medical wing of the civil rights movement. And they really worked hard to try and end segregation and substandard medical care for Black folks. Of course, state governments, mostly in the South, did everything they could to resist integration, including threats and acts of violence with the KKK. It wasn't really until the birth of Medicare and Medicaid that the federal government was able to see through integration of medical facilities, basically via threats, basically via saying, we have all these Medicare and Medicaid dollars, and you, the Southern states, are not going to get them unless you integrate your health facilities. I also want to take a moment to talk about Henrietta Lacks. Many of you may be familiar with her as her story has recently gotten more attention, but she was a Black cancer patient, and in 1951, her cells were harvested without her consent. And those cells turned out to be amazing. They were the first human cells to ever be cloned, and they've been used in biomedical research from in vitro fertilization all the way to the creation of the COVID-19 vaccine. And as such, her cells have been sold for millions of dollars. Her descendants are currently involved in a legal battle in regards to that because, she did not give consent for her cells to be taken. And these medical technology companies are profiting off of the cells from her body. Also want to mention the Cincinnati experiments, which was a funded study by the US Department of Defense to study how soldiers in nuclear war might be affected by large doses of radiation. So these experiments were conducted without patient consent for the first 5 years of the study. And 88 cancer patients ages 9 to 84 were intentionally exposed to intense doses of radiation, and their responses were recorded. Many of those people died of radiation poisoning. And then a very recent instance of exploitation in the medical field is the 1993 Baltimore lead paint study. So this was through Johns Hopkins University, and it was an experiment to test different ways of abating lead paint. And so many children, mostly African American, some as young as a year old, were exposed to varying levels of potentially dangerous lead paint as a way to kind of test these different methods. I also want to take a minute to talk about mistrust in immigrant populations. So we have a large immigrant population in the US, almost 40 million people. And each individual who immigrates to this country brings with them good or bad experiences of the medical system in their home country. And there's also a learning curve, learning the differences between how the health system worked in their home country and how it works in the US. Refugees and asylees especially may carry trauma from these experiences, and that impacts their trust here in the US. This is important because hospice is still a young movement, and hospice is more prevalent in the US, Europe, and Australia. So many immigrants from other parts of the world may have no previous experience or no idea what hospice is. It's also important to remember that we have many different immigrants from many different countries who bring with them their own sets of beliefs and cultural norms. And so it's really important that providers not only speak their language, but understand those cultural norms. Another huge issue with trust in immigrant populations is public charge. So many immigrants fear that if they access different healthcare services, they will go on the public charge list. So this basically means that there have been in the past laws that say, if someone is here in this country as an immigrant and they are getting certain government benefits, that makes them a public charge, and that makes them less desirable for citizenship or more likely to be deported. So the Trump administration had implemented some changes that broadened the scope of public charge, and that included non-emergency Medicaid and food stamp assistance. So that led to a lot of confusion, a lot of fear in immigrant populations, especially among undocumented folks. The Biden administration has since reversed that, but a lot of fear remains with the fact that laws tend to vary depending on the administration in power. And then finally, talking a little bit about current discrimination and inequities today. We talked about social determinants of health, so we know that certain communities do not have the same access to resources that they need to be healthy. We've also heard a lot recently about implicit bias. So this refers to an unconscious bias or a set of beliefs that are activated automatically in us without us really being aware of it. So you might have seen that popular YouTube video where it talks about, if I say peanut butter, many of you are automatically going to think jelly, just because peanut butter and jelly have gone together in our society. So it's like automatic. The same can be true about discriminatory beliefs. You know, we have all come up together in this racist society. And so many times we may have negative associations, stereotypes that we aren't even aware of. So no one is immune to this. Regardless of your race, or if you work in healthcare, you can still be impacted by implicit bias. So we really need to work to be cognizant of what biases we do have so that we can remove them, work against them, and do better. I think it's also important to note, I talked previously about eugenics and some racist, as an example of racist science, junk science. Science is not immune to racism, right? And we've seen this with recent surveys of white medical students, so students who are studying to be physicians. And a survey they did at University of Virginia showed that about half of the people who were surveyed, the future doctors who were surveyed, held false physiological beliefs about African Americans. So many of them, nearly 60%, actually believe that African American skin was thicker than white skin. And 12% thought that the nerve endings of Black people were less sensitive than those of white people. So of course, this is completely false, but you can see how this could impact people's care, because if medical students don't believe that Black people or people of color experience pain in the same ways as white people, that can lead to people of color not getting adequate pain management. So these types of studies are really important to show that these issues still exist. I just want to talk quickly about a personal example of a real person who I'm going to call Tanya. So Tanya was a African-American individual woman born in the 40s, lived through Jim Crow segregation. And as a Black woman, she experienced blatant discrimination. But more recently, she was diagnosed with uterine fibroids, a condition causing bleeding and pain. And when she went to seek help at her doctor, she was told that she needed a hysterectomy to have her uterus removed. And she was concerned about this major surgery, so she sought several second opinions. And the fourth doctor that she saw finally let her know that she didn't need a hysterectomy. There was less invasive treatment she could have. I tell this story as an example of how self-advocacy is exhausting and how African Americans continue to be offered substandard care. Those first three physicians really failed Tanya, and each time that happens, it serves to reinforce the idea that as a Black woman, she cannot trust her doctors. So if we fast forward 10 years, Tanya's diagnosed with terminal cancer, and her doctors say, you know, this cancer is incurable, we recommend hospice care. How do you think Tanya will respond? Do you think she will believe her doctors and trust them? Or do you think that maybe she'll think hospice care is giving up? Hospice care is substandard, there really is a cure and they're just not telling her about it. So that's an example that I'll return to later in the presentation, but I'm going to throw it over to my colleague to keep going.
Is this me?
Yes, Kandis.
So implications for hospice care. Got this quote from Jerry Powell, and it says, historical discrimination against communities of color has resulted in an understandable distrust of providers that continues to be an important barrier to accepting a poor prognosis, entertaining hospice enrollment, or perceiving palliative care as something other than second tier care. Trust is an essential ingredient to qualify end-of-life care, and the lack thereof remains a durable barrier to achieving that goal in many communities. Next slide. So here's the impact of mistrust on end-of-life preferences. Only 18% of minorities participate in advanced care planning, and compared to 34% of white respondents. And as a group, for the most part, Black Americans are more likely to opt for aggressive life-sustaining treatments at the end of life. And people that live in historically marginalized communities living in poverty are most of the time too busy trying to survive, which means that their health can take a hit, and they often don't think about what they want at the end of life. So when we're doing our day-to-day lives and when we're going through things, you know, if I have to just wonder how I'm going to eat, or whether or not my rent is going to get paid, or whether or not I'm even going to have gas to get to work, often what happens is that your physical body suffers, and that can happen easily. So, and that happens a lot in underserved communities. And in many minority communities, the care of the dying is the duty of the family. Often when I do caregiving presentations, this very fact comes up about how in many African-American communities and in some Hispanic Latinx communities, when there's a family member that is passing away, or if there's a family member that is in their end of life stages or going through something, having a very, very chronic illness, often a family member will step in and take on those responsibilities. And often it's not because people don't know that certain things are available to them, but because there was such a, as Maureen mentioned and further before in the presentation, that there has been such a history of mistrust, you know, often with doctors, care facilities. Most people believe that they can care for their loved ones at home. So that's a common thing that happens with minority communities. Next slide. So now that we've gone through the history, we've gone through the mistrust, and we've gone through different quotes, and we've talked about utilization and different things like that. Now we're going to what now? So the truth is that there are no easy solutions. You know, it's good to listen, acknowledge, recognize, prioritize, and invest. And what would be very, very helpful in this space would be diverse and culturally humble staff, meaning individuals who know how to speak to certain communities and knowing how to have proper bedside manner, and serious illness continuum of care, and expanding palliative care. And this is a perfect space to utilize community health workers, community education associates, also patient navigators are also good when it comes to things like this, because they serve as they can break information down more and for people to understand if there's something that the doctor is saying that they don't understand, or if there's something that's going on that they need more clarification about. This is where community health workers and patient navigators can come in. Next slide. So, you know, the only way that you change anything is that you have to acknowledge, reckon, prioritize, and invest. And the first step for any healthcare entity is to acknowledge their own responsibility and the role that they have played in medical mistrust, or not having a culturally diverse staff, and also why there are not enough minority people of color and on staff, or when you are serving people of color, that needs to be a priority. Also, you know, invest the time and money that you need to do better. These healthcare entities need to do more, need to be more cognizant of that. And finally, to ensure empowerment without paternalism. Next slide. So building diverse and culturally humble staff, as we mentioned before, ensure all clinicians understand the legacy of medical racism and its impact. Expanding the diversity of the hospice workforce, making sure more people of color are on staff. Education on cultural humility. You know, we had a conversation about this. I attended a session on maternal health earlier this week, and we talked about implicit bias, and we talked about cultural humility. And it was brought up that sometimes cultural humility should start as soon as medical school, as soon as they're doing rounds in the hospital, as soon as they start seeing patients, or even if they're going to be placed in certain communities, depending on where they're serving, education on how to speak to certain communities would be helpful. And understand that cultural humility and how important it is, and understanding that cultural diversity takes a personal journey, meaning, you have to study the histories and oppressions of discrimination, understanding that most people, as Maureen mentioned, feel the way they feel for a certain kind of way. And it takes time to undo that. And you have to open your mind and heart as a healthcare entity, and also as doctors or clinical staff in general, to develop cultural humility. Looking in, how do I take responsibility? I look at my own assumptions and my own prejudices, things that I may have against certain people, or things that I may not know in general, looking at where I may fall short in that area, and putting aside your assumptions when working with clients. You assume this person doesn't have money. You assume that because they look a certain kind of way, you don't want to talk to them. You assume that because you see a tattoo, that means that they're, a part of a certain, part of town, or they're part of a gang. It doesn't mean that. Each person that comes into a facility deserves quality care. And finally, being respectful to clients. This is a big one. A person's decisions, it's truly their own choices. And you have to be respectful of that, whatever they choose. Next slide.
So I'll pick it up here. Another important thing for those of us who work in serious illness is to really expand the continuum of care so that patients have more options and also more time to allow providers to build trust with those patients. So what I mean by that is increased touch points and education before patients have a terminal illness. So this is exactly what Kandis and I do. When we go out and we give free presentations in the community, most of the people attending a presentation that explains what hospice care is, they don't need hospice care at that moment. And that's kind of intentional, right? We want to have people have a chance to be educated and familiarize themselves with these types of care before they actually need it, so that they can make empowered choices. Also, it's really important to educate and expand palliative care. So we talked a little bit about how hospice is comfort care at the final stage of a terminal illness when cure is not the goal. Palliative care is similar in that it also focuses on comfort care and quality of life, but palliative care is available at any stage of a serious illness. You don't have to be dying to get palliative care. And also, you can get palliative care while pursuing curative treatments. And I think that's an important distinction. So I'm going to go back to that example that I mentioned earlier of Tanya with a diagnosis of terminal cancer. Her doctors recommended hospice, and she didn't really believe them. She wanted to try chemotherapy, even though they said it wouldn't work. So she did pursue chemotherapy, but she had a friend who was a nurse, and that friend was familiar with palliative care and told her, why don't you get palliative care at the same time that you're getting chemotherapy? And so she did. So while she's fighting the cancer, we all know that chemotherapy can save lives, but it can really ravage your body. So while she was doing that, she had a palliative care nurse that really worked to help manage her pain and also the side effects from the chemo. And they also helped her with the emotional roller coaster that is a cancer diagnosis. So after about a year of chemotherapy, she decided that she was done with it, and she did opt for in-home hospice care. So what I want to draw your attention to about this example is that it gave her the option to fight her cancer and still access holistic symptom management with palliative care. So that's really important. And then when she was ready, when she made the decision that she no longer wanted curative treatment, it was a smooth transition from palliative care to hospice care because she had gotten to know those providers and how they had helped her. So that's just an example of how expanding palliative care is really important in giving people choices and also in building trust and building relationships. And so I want to talk a little bit about community health workers. This is a group by and for community health workers. Many of our members and folks in the audience are CHWs. And I think our role can be really important here. Many of you may work in different spaces, right? Kandis and I work in serious illness, but not all CHWs do. But one thing we have in common is that CHWs often come from the communities they serve. So we are often culturally competent. We understand the cultural norms of a community. And we can be a great starting point about conversations about serious illness or access to healthcare resources. And we can really work to build and rebuild trust. You know, CHWs are typically trusted messengers because we have one foot in the community and one foot in the healthcare system. We also advocate for community health workers to be members of care teams, palliative care and hospice care teams, helping to support the needs of patients and their loved ones. CHWs have an opportunity to educate not only the community, but also the providers. So I think this is really important, just as Kandis and I and our colleague Jenny go out into the community and educate community members about hospice and palliative care. We also go back to our organization, the HAP Foundation, and educate them about what's going on in the community. What are the needs of the community? What are the assets or the barriers to care? And then through that, you know, we can work with the HAP Foundation to then go out to clinicians who are actually providing care and offer education and training to them to make sure that they are meeting the unique needs of each community and each population. So it's really important that organizations that employ community health workers keep those channels of communication open and really value the input of CHWs. Kim, I think it's back to you.
I think it is. Thanks, Maureen. So I'm going to bring us home here just by sharing a little bit about the HAP Foundation and who we are and what we do in this space. So at the HAP Foundation, we work to improve access to quality serious illness care. And we do this through education, advocacy, workforce development, and research. And just to give a little bit of detail and specificity around how we do that, I'm going to tell you just a little bit about a few of our programs. So as Maureen was just saying, in the education space, we have a community health worker program that provides community-facing education. They oftentimes are educating clinicians, working in advocacy, and providing connection for families and individuals in the serious illness space. In the research space, we have a community engaged approach for most of our projects, and we seek to really deeply understand issues around access and disparities so we can better serve and better create pathways to access to hospice and palliative care for communities that have historically been underserved by that service. We do some work in the grief space. We have a program called Missing Pieces. This is a grief navigation program following child loss, where families are connected with one of our grief navigators following the loss of a child or infant to help the family and sometimes to help providers or organizations like schools to connect to community resources that would be a good match for grief support. This is a program that has an increasing presence in the space of perinatal and infant loss, and also a strong relationship with several of the coroner's offices in order to really reach and support families following the loss of a child. In the advocacy space, we are working right now with Medicaid to finalize a state plan amendment that will change the way we deliver care to children with serious illnesses in the state of Illinois. It will allow children who have certain diagnoses to receive palliative care services from a community team at the time of diagnosis. And HAP also worked this year with legislators to pass legislation in the private insurance sector for a program to mirror this for private insurance programs in Illinois. And we really hope this will be transformative for children and families and allowing them to receive true palliative care in the community from the time of diagnosis in a way that follows their goals of care and their needs. All right, next slide. And just as the, Executive Director of Research, I just needed to give a quick plug for the HAP Research Program. I have the really good fortune of being in this role at HAP. And I just thought I would take a moment to share how different my role is from individuals in the academic research setting. I really feel a really cool space of collaborative research We have multiple research projects percolating right now, but they're all in partnership with various academic organizations. So our strength, instead of lying in being a PhD researcher or a lead researcher, really relies on understanding the process and the importance of community engagement, and in sort of filling the role of providing community, organizational, and individual input to research projects, both what needs to be studied and how projects are developed and formed. I can just sort of skim over this slide, but just really as a follow-up to this presentation, really just commenting that at HAP, we really try to take research from a community-based participatory research approach. And what that means is that we really equitably seek to involve community members and community organizations in all aspects of the research project, having them drive the project, looking at what the community needs and what the individuals that need in the community needs from the moment the research concept is created all the way through dissemination and ownership of the research findings themselves. Next slide. And so I think that just brings us to some conclusions. Just looking at things we'd like you to take home from this presentation. So Maureen, maybe I'll pass it back to you just to wrap up and then open the floor for any questions that people might have.
Sure. Thanks, Kim. So really, we just want y'all to walk away understanding that there is a long legacy of racism and abuse in healthcare, and both that historical legacy and what's going on currently today has damaged trust for communities of color. So trust is always important, but it's especially important when it comes to something like hospice care, because when someone is facing a terminal diagnosis, they are at their most vulnerable. And these care teams are usually coming into people's homes to provide care. So that's a very kind of intimate setting. And it's hard to deliver that care without trust. So that medical mistrust and other barriers contribute to the low hospice utilization rates for racial and ethnic minorities. So it's a key focus for us at the HAP Foundation with our CHWs to work to address those disparities in hospice utilization. And it requires commitment to rebuilding trust and expanding education about palliative care for serious illness. It also involves a commitment from all people in healthcare to work towards a diverse and culturally humble staff of workforce, of clinicians, of CEOs from top to bottom. And also that providers of care really should partner with CHWs and other trusted messengers, including people who, come from faith communities, because these trusted messengers, when utilized appropriately, can really help to build trust. So I have a few reference slides here, some of our citations, and then finally, this is our survey. We ask y'all to complete a brief anonymous survey. This helps us for our funding and also to kind of see how we're doing and, if these presentations are impactful. There's also our email address, and the survey link is also in the chat. So you can click on that survey link in the chat and it'll open a new window, or you can scan the QR code.